Assalamualaikum warahmatullahi wabarakatuh. My name is Udaimatunnur Binti Muhammad Baharuddin. My clinical supervisor is Pondor Ili Binti Muhammad Tamizi, and my academic supervisor is Dr. Mahzina Binti Muhammad. I was placed in Klinik Kesihatan Cukai Kemaman for my clinical placement. Today I would like to present about my case study, which is inadequate gestational weight gain and stunting or banted. We go to case study 1, which is inadequate gestational weight gain. Mrs. A is a 37 years old lady. She is married and currently living with her husband and 3 kids. She is a school cleaner and her husband works as a van driver. Currently, generally, she was having a family background which considered as B40 socioeconomic status. She do not have any history of inadequate gestational weight gain. This is her fourth pregnancy, and she had hyperemesis gravidarum at 18 to 21st weeks of pregnancy. She was diagnosed with inadequate gestational weight gain on her 23rd week of pregnancy, where she only gained 0.5 kilograms of weight during her second trimester. Generally, inadequate gestational weight gain risk factors appear or are diagnosed only after the first gestational trimester. Hyperemesis gravidarum is characterized as an extreme form of nausea and vomiting in pregnancy. CDC 2015 reported that inadequate gestational weight gain occurs in more than 20% states. The causes of inadequate gestational weight gains are weight loss of at least 5% compared with pre-pregnancy, hyperemesis gravidarum, and impairment of oral intake. Determinant factors that can cause inadequate gestational weight gain vary due to socioeconomic status, educational level, maternal age, pre-pregnancy BMI, dietary practices, and physical activity level. The consequences of inadequate gestational weight gains are maternal and perinatal mortality, premature or low birth weight baby, and small for gestational age. From Mrs. A's past medical history, it shows that in 2016, she had premature delivery at 27 weeks of pregnancy with 660-gram baby girl. In 29 May, eh, At 29 March 2022, she went to a health clinic after having hyperemesis gravidarum for 1 week. A UPT was done and it turns out to be positive. At 7 May 2022, she went to the MCH clinics, which is Mother and Child Health Clinic, for regular pregnancy appointment. At 14 June 2022, she was first referred to nutritionist for dietary consultation due to her inadequate gestational weight gain at 23rd week. This happened with her fourth pregnancy. For condition dietary relation, which is inadequate gestational weight gain, it is indicated by her static and insufficient weight gain, which is 1.5 kg at second trimester. It is caused by her low intake of food portion, inadequate macronutrients intakes, deficiencies of vital nutrients, and low intake of variety of food components, which leads to inadequate gestational weight gain. Table 1 shows her weight progress throughout her pregnancy. It is shown that on her first booking week, at her 20 weeks of pregnancy is 57 kilogram, and her second trimester weight is 58.5 kilogram. She only gained 1.5 kilogram for the 11 weeks of period. She did not achieve recommended gestational weight gain at her second trimester, which is 5.29 kilogram to 7.59 kilograms. For medication or drugs, on 29 March 2022, Mrs. A was given T-zinc copper to be consumed every day after meals. For nutritional assessment or intervention, SOAP assessment was implemented in Klinik Kesihatan Kemasik. Her first visit was on 14 June 2022 and recorded as a new case. At that moment, she was with her fourth pregnancy. Her booking weight is 57 kg and her booking BMI is 26.4 kg meter per square. Her current weight is 58.5 kg. She was diagnosed with inadequate gestational weight gain at her 23rd week of pregnancy. Her blood pressure is 114/88 mmHg and her pulse rate is 82 beats per minute. And her hemoglobin level is 11.9 gram percentage, which is normal. After calculating, her total weight gain was only 1.5 kg. However, her recommended weight gain at 23rd week, which is second trimester, is 5.29 kg to 7.59 kg. The objective for her first visit is to achieve recommended total gestational weight gain for the next appointment and to ensure Mrs. A achieves recommended energy intake approximately 1,700 kilocalories per day. For assessment, we use 24-hour diet recalls to identify Mrs. A food patterns and energy intake. We found out Mrs. A takes an adequate energy intake. However, she did not take a variety of foods for every meal she take, and she had low intake of green vegetables. She also had a small appetite after a series of hyperemesis gravidarum. Even though Mrs. A showed a good appetite of eating, however, she showed a slow pattern of weight gain. For the plan, we explain about effects of low gestational weight gain to Mrs. A. We ensure Mrs. A to increase her food frequency to 5 to 6 meal time per day. We increase her intake of carbohydrate to 2 rice cubes per servings and increase intake of protein 2 servings per day, which help for fetal growth and development. We also ensure Mrs. A to take variety of healthy food. We ensure Mrs. A to take vegetable 3 servings per day, fruits 2 servings per day, and drink enough water 6 to 8 glasses per day. We ensure Mrs. A to take variety of food component and increase her diet rich in vital nutrients for growth, development and immunity such as protein, iron, vitamin A, vitamin C, vitamin D, calcium, zinc, and iodine. Her next TCA will be on July 2022. Inadequate gestational weight gain is a condition where pregnant women fail to increase or insufficiently increase their weight to the recommended weight during pregnancy. A study by Morisaki et al. 2022 stated that among 91,313 pregnant women, 5,196 lost over than 5% of their pre-pregnancy weight. and 9,983 experienced hyperemesis gravidarum and were unable to eat in the first trimester. Pregnant women suffering from hyperemesis gravidarum usually lose substantial weight during early pregnancy and often struggle to achieve the recommended pregnancy weight gain. She was also advised to increase her balanced meal to 5 to 6 times daily. She has to eat even though the same menu for the day to avoid loss of energy because her works require more energy. She had to increase her intake of protein to 2 servings per day, which helped for fetal growth and development. Mrs. A also advised to increase intake of carbohydrate to 2 rice scoops per serving and make sure to take vegetables 3 servings per day and fruits 2 servings per day. Therefore, medical officer, nurse, and nutritionist has to work together to keep remind and inform the inadequate gestational weight gain mothers to properly take care their dietary intake and the importance of achieving recommended gestational weight gain during their pregnancy. As a conclusion, small consumption of food portion and varieties, especially green leafy vegetables, protein, carbohydrate and fat sources due to her low appetite during and after her episodes with hyperemesis gravidarum could lead to inadequate gestational weight gain in Mrs. A. A proper advice and consultation has been given to the mother on balanced diet according to the calories needed by the patient and she has understood clearly on the advice. Given the risk of inadequate gain during a high-risk pregnancy and the fact that gestational weight gain is a modifiable factor, the importance of additional support and health counseling, particularly nutrition education interventions such as a health promoting tool for pregnant women and fetus is highlighted, particularly for women who are more socially vulnerable and have lower level of formal education. Mrs. A next TCA is on June 2022. However, I cannot continue to observe her next progress as this is a new case of inadequate gestational weight gain and because I have already ended my first industrial training in Chukai Health Clinic. We move to the next case study, which is case study 2, stunting or bantu. Boy A is a 1-year-old and 9 months Malay boy. He was born on 27 August 2020. He was the third child out of 3 siblings and not yet entered school. Her mother was a full housewife. Due to this new case, there was not much socio-economic and social status of boy A can be extracted. He was referred to a nutritionist for dietary consultation because of her poor height increment starting from 9 months old. According to his mother, boy A started to frequently getting fever since he was 9 months old. However, he was actively moving around and doing activity with his siblings. He also was born full term at 39 weeks. Stunting is a proportion of children whose height for age is more than 2 standard deviations below the WHO's child growth standards median among children under 5 years of age. Stunting is one of the indicators used to measure nutritional imbalance, which results in either undernutrition, where was assessed from stunting, wasting, and underweight or overweight. The causes of stunting could be from the chronic or recurrent undernutrition, frequent illness, inappropriate feeding and care in early life, and dietary diversity. The risk factors also can come from socioeconomic status, child feeding practices, past medical conditions, parental education, and household income. This global issue could lead to serious consequences, which are morbidity and mortality risk, non-communicable disease later in life, and low development in cognitive, language, and sensory motor skills. For disease-dietary relation, which is stunting or bantu, there are four broad subforms of undernutrition, which are wasting, stunting, underweight, and micronutrients deficiencies. Related to boy A, he has low high 4H, which is stunting, indicates by his growth chart showing poor high increment and inadequate calorie intake. All of these inadequacies are leading to stunting. For medication and drugs, there is no record of medication in boy A's health book record, and there was no also drugs were given to the patient as he is referred as undernutrition. For nutritional assessment or intervention, SOAP assessment was implemented in a Temasek Health Clinic. Boy A's first visit was on 14 June 2022. For the subjective, we found that his weight for age is 7 kg, which is normal, and his length for age is 77.5 cm, which is stunted. His BMI is 16.6 kg per meter square, which categorized as normal. He was born full term on 39 weeks of pregnancy with weight 3.085 kg. He was exclusively breastfed until 1 year old, and his mom admitted she had lack of breast milk. His mother stated that boy A just get well from fever, and she also complained that her son lost his appetite because of sick and slowly getting back his appetite. For the adjective, we want boy A to achieve his actual length at 1 year and 9 months old, which is 85 cm, within the range 79.5 cm until 91.0 cm. As recommended for children, his length should increment to 1 cm per month. Second, to ensure the child has enough milk intake to promote optimal growth, and to ensure the child achieves estimated energy requirement approximately of 980 kilocalories per day, which include protein, vitamin A, vitamin C, calcium, iodine, zinc, and iron. For the assessment, we use 24-hour diet recalls to observe boy A's uh, calorie intakes. Based on the 24-hour diet recalls, we conclude that uh, he had adequate calorie intake, which is 980 kilocalories per day. However, he had poor high increment, even though his eating appetite was good. For the plan, we suggest the mothers to increase boy A's food frequency to 6 to 7 times per day, and suggested the mother to have early breakfast for boy A. He should consume plain water approximately 5 cups per day, and she has to continue to breastfeeding boy A on demand until 2 years old. We also suggest the mother to increase boy A's diet rich in vital nutrients for growth, development, and immunity, such as protein, iron, vitamin A, vitamin C, calcium, and iodine. Adequate nutrition from the early stages of development serve as a window of opportunity for proper growth and development, particularly during pregnancy and the first 2 years of life. Globally, almost 165 million children under the age of 5 are stunted. Boy A was in observation for his length since he is 9 months old and diagnosed as stunting at the same age, only referred to nutritionist after 12 months due to his poor height increment. So the main concern of this patient are small intake of amount of energy and does not get enough of vital nutrients due to his impaired appetite. His current illness also could lead to stunting. Recommendation for boy A was delivered through her mother. Her mother was suggested to increase his food frequency to 6 to 7 times per day, where she can change their time for each meal and suggested for boy A to have early breakfast for the day. She need to continue on breastfeeding on demand until boy A is 2 years old in order to increase and strengthen his immunity. Lastly, the mother was suggested to increase boy A's diet that rich in vital nutrients for his growth, development, and immunity such as protein, iron, vitamin A, vitamin C, calcium, and iodine. According to WHO 2001, in order to combat the rising issue of undernutrition, the meals offered must be sufficient in terms of calories, protein, and micronutrients to meet the requirement of children, functions for their body growth and development. It may be concluded that boy A was having poor height increment, which fall into stunting category, started from 9 months old due to getting fever frequently until he was referred to nutritionist on 14 June 2022. A proper advice and consultation has been given to the mother on balanced diet according to the calories needed by his son and she has understood clearly on the advice. The next appointment TCA will be on August 2022. And since this is a new case of stunting, I cannot continue to observe his next progress as I already ended my industrial training in Chukai Health Clinic. That's all from me. Thank you.